of us could have gotten world-class healthcare with the money we are spending, but we are not. The other half just don't have enough money. And the evidence is that the best providers are salaried, not piece rate workers, not contract workers. Unfortunately, a lot of startups that have engaged in these spaces, they haven't innovated fundamentally. What they have done is they've taken offline processes, made them online. But the underlying problem, they have not solved. In fact, in some cases, they made it worse. The country has no shortage of passionate people. What we lack are passionate people with deep skills. Credit is like a road. You can't say, I'll build a road only for poor women.
Right.
It must be a broad, high-quality road that anybody that is not drunk should be allowed to travel on with no difficulties. And if there is a toll to be paid, they must all be charged a reasonable toll. If I look at credit to GDP ratio, for example, as an indicator of how easy it is for them to access credit, some of the poorest districts of India just don't have enough credit. Allow the non-bank finance company a lot more freedom, a lot more play, no need of capital regulation until they cross 50,000 crores, 100,000 crores.
Hello and welcome to another episode of the KVKurious Podcast. Our guest for today is Dr. Nachiket Mor, who has been an Indian banker, previously the National Director of Bill and Melinda Gates Foundation, and is currently working at the forefront of healthcare policy in India. In this conversation, Dr. Nachiket throws light on how, as a country, as a nation, and as startups, we can solve for access to credit, access to better and affordable healthcare, as well as access to insurance. So listen to this conversation with Dr. Nachiket on the KVKurious Podcast. Hi, Nachiket. Wonderful to have you on my podcast. Looking forward to discuss around developments in healthcare, rural developments, and your journey over the last 2 to 3 decades. Thank you for being on my show.
No, happy to be here. Thank you for having me.
Sure. So I was recently reading a paper on, arriving at the pricing and the model for healthcare, universal health coverage in India. And one of the things that really stood out to me was it varies depending on the state. The per capita expenditure varies depending on the state. So what do you think is the ideal way to implement UHC? Should it be at, let's say, jurisdiction levels? Should it be at district, city levels, or state levels, or national level, or international level? What do you think is the ideal way to implement this?
The reality is that you have to start with what the disease burden in a particular community is. Right? There are common principles of what universal healthcare looks like, and one could argue that they could be national, even if not global. Primary care, academics like Dr. Barbara Starfield have laid down some structure of what good primary care looks like. Whether you offer that primary care in India or in Costa Rica or in Brazil, these principles would be similar. But how we turn them into actual implementation on the ground could be very, very different. And you would have to allow a lot of local play, at least at the state level, if not below that, in order for that to happen.
So when you say allow a lot of local play, do you mean in terms of participation or in terms of decision making?
I mean, design itself.
Okay.
For example, a state like Kerala is able to offer its state and its residents doctors, nurses, as many as are needed. Whereas, perhaps a poorer state in the north might not be able to do it. So therefore, any solution that we decide, are we going to deploy doctors? Are we going to deploy nurses? Are we going to deploy community health workers? Would change. Technology. If I was doing something in India, I would say I would aspire to using the latest and the best technology. If I was instead trying to do something in another country, elsewhere in the world, where technology capability was not that strong, I might not be able to do it quite in the same way. So the actual conversion of the principles into what is done on the ground would have to be done fundamentally differently.
Right. So I understand that there is an interplay of two things here when it comes to design. One is how well can you leverage technological advancements to achieve your vision at scale, And how good is the, let's say, the team that's developing the design, the people who are actually executing this? What do you think is sort of the right balance between the two, and what makes for an ideal team?
No, as I said, I think at least at the state level, the designer would have to sit there. So we have 35, 36 state plus UTs, and they would all have to have their own design. It would not make sense for us to impose a single design across the country. Now, where they would start is look at their disease burden, look at their resource envelope, look at what kinds of people they have, what kind of people they don't have, how do their populations react? Cultural aspects also become quite important. There are some cultures that are much more open to, for example, guidance. Some cultures, if you look at Britain, why were they able to impose the NHS? Because they had come back from the war, where the rich and the poor, the gentlemen, they are all fought together in the war, side by side in the trenches. So when they came back, it was acceptable to people that we all should have a common healthcare system, not something for the rich and something for the poor. Now, that might not be acceptable to another environment where they've not had that kind of Dalit movement or something else. Right? They might say, no, let this be on the basis of how much people can pay, what kind of financial and other capabilities that they have. So these are issues that one would have to incorporate. In Thailand, for example, steam baths are permitted as a primary care treatment. Brazil permits exchange operations as a part of its universal health care. So again, it's a matter of who you are, what your background is, what your environment is. At least a state level decision maker would have to take all that into account as they think about what is the right structure. Primary care, should it be offered in the community or should it be offered inside an OPD department of a hospital? Now, it depends on your structure. Do you have villages that are tiny, situated in remote areas, like in the Northeast? Or are you like Kerala, where effectively there is a high degree of urbanization? And that it doesn't make sense to imagine little clinics dotted around everywhere. There's enough population ability to do all of this inside a hospital. So these are big decisions that have to be taken on the basis of what actually is the environment on the ground.
Interesting. I get it. This sort of forces me to ask the question. There's been a lot of debate around for decades around universal basic income as a concept, and people think it's a very socialist approach. Do you think it's fair to look at universal health coverage through the same lens, or do you think it's very different?
So again, it's a matter of how you imagine. And this is, as I said, a lot of this is cultural, a lot of this is social. What is the belief people have? If, for example, we have the view that the role of the state is building your capacity, but then you fight in the market and whatever you win, what you don't win, you don't win. Right? That's a very different structure from saying, no, the state is like a joint family. Everybody needs to be protected. No matter what their capability, they must have an equal standard of life. They must all live well. And we therefore need to think about a different approach towards solving this issue. Right? Now, in India, we have, unfortunately, somewhat of an awkward situation where, if you look at the data, it suggests that the top 100, maybe 200 million people, if you stretch it, capture most of the benefits of growth. Most of the wealth sits with them. And the balance, billion people or 1100 million people, are really not benefiting a great deal from what is going on in the country. Right? Now, the question is, what is our view about them? If we say, I am a growth-oriented person, what I'm effectively saying is, I'm going to focus on the lives of these 200 million. And that, if they do well, I believe we as a country have done well. And that could be one direction to go. In such a situation, one would say, why would I bother with universal healthcare? let people figure out what they need to do. Those who can afford it, get it. Those who can't, don't get it. Right. Now, the trouble a little bit with universal healthcare or healthcare in general is that in an economy like ours, where labor is not in short supply, it's been hard to make the argument that if I give you an additional hour of labor because of improved healthcare, it will benefit the economy. Because it won't. I have enough people already. In fact, I have hidden unemployment. In education, one can make that argument, because in education, you are skilling whole swaths of population. Right? In health, it's a little bit harder to make it. Right? And data, if you look at the regressions people run, they've not been able to make that connection easily. In which case, the argument for universal healthcare often boils down to a welfare argument. To say, well, the rich perhaps can afford their own healthcare, though I would submit to you that given the current design, neither the rich nor the poor are getting it, because markets are failing for everybody. But if you forgot that for a minute, at least the top 200 million can purchase some form of healthcare. The others can't. Then the argument becomes very much welfare, and then you have to go back to the government and say, what is your worldview, or what is the goal of the nation? How are we moving forward? Are we building capability and letting people, survive in the market as they do? That's one pathway. And the other pathway is the welfare pathway, in which one is saying, I will make sure that everybody has a minimum set of needs taken care of really well. And then beyond that, perhaps I will let the market figure it out.
Okay, I want to dig a little deeper into that. When you say welfare and when you define it as, is everyone having access to a bare minimum set of needs taken care of? And let's say policies came in place and universal health coverage came in place so that this was actually implemented. Now we essentially have, like I mentioned, about 1 billion or 1.1 billion people whose basic needs are taken care of, but they still have nothing to contribute to the economic activity, simply because there might not be enough opportunities to allow them to participate. But would you contradict that by saying that the moment that their basic needs are taken care of, they are capable of themselves generating opportunities? And if so, how?
I mean, I definitely would agree with that point of view. What I would say, though, is the cycle time may be a little bit longer. You may have to invest for a while in order, because the deficits are quite large. If I look at the educational outcomes of that group, if I look at the health situation of that group, it's not very good. If I look at credit access, if I look at credit to GDP ratio, for example, as an indicator of how easy it is for them to access credit, some of the poorest districts of India just don't have enough credit, right, as compared to their GDP. Right? To give you a kind of set of benchmarks, Thailand is at 180% credit to GDP ratio as a country. We as a country are at 50%. Right? If I now say, if I take out the credit to GDP ratios of the high-performing states, high-performing districts, which is not even states, it's districts, how much is left for the others?
Right.
Now, I don't have the most recent numbers, but my last memory of these numbers is many states and districts have not even crossed 20%. Now, if you don't give even bare minimum credit access, how do you expect them to get growth going? And it may be intergenerational. It may not be that you give the credit access today and you see the growth tomorrow.
Right.
It may take a little bit of time for the economy. But, to your point, as an economy that is slowing, right, and we are worried now about a much lower rate of growth, I don't see an alternative but to follow this pathway. To focus on the poor, to build something that makes sense. And in health, the point I was trying to make earlier, it's not even as if it's just for the poor. A good health system benefits the rich and the poor.
Okay, how?
For example, if I look at statistics today, which state do you imagine has the best health system? Everybody would say Kerala. Which state has the highest burden of hypertension, dyslipidemia, diabetes? Kerala. You might say, well, how is that consistent with the previous statement? The reality is the Keralites are spending a lot of money. They're not getting good healthcare because the healthcare needed for dealing with these diseases is almost the opposite of the current design of their healthcare system, which is very hospital-centric, which doesn't have enough primary care. And some of these diseases, you cannot leave it to people to decide because oftentimes hypertension, dyslipidemia, diabetes are invisible diseases. I need the health system to reach out to me.
So you're suggesting that the problem is lack of diagnosis, lack of awareness.
Not just awareness, right? If awareness is the only problem, there'd be no obese doctors. Right? It's not just awareness. It is somebody working with me, counseling me, working with me every day to make sure I adhered, I complied, I took the medicine, I showed up for treatment, I showed up for checkups. What they call proactive primary care. Right? Worldwide, this is the form of primary care that exists. If I look at UK, if I look at France, if I look at Thailand, if I look at Costa Rica, if I look at Brazil, all of whom have built very good primary care. If you are enrolled with your primary care provider, the primary care provider is as responsible for your health as you are. And if you are at high risk for diabetes and you haven't shown up for 6 months, she will call you. Or she will come to your home and say, sir, you have not shown up. I need to check your blood. I need to check what's going on with you. Now, nobody's getting that kind of care in India. Neither the rich nor the poor.
Is it because we are not willing to incentivize these healthcare providers enough for them to be so proactive?
My sense is that we haven't even thought about it. It's not that, because incentive is not, we are paying our providers well. It's not as if they're not getting paid well. And the evidence is that the best providers are salaried, not piece rate workers, not contract workers that are paid for this and 2 rupees for that and 5 rupees for something else. That's not the best providers. The payment model, for example, every country has, again, as I said, these are all issues of social, cultural importance, but many countries have gone with what they call a capitated model, in which once you are enrolled with your healthcare provider, the healthcare provider gets once a year a fixed sum of money on your behalf from the government. Now, he or she is told that all costs of actual treatment will have to be borne by you. No more money will come.
Interesting.
In that case, you immediately become focused on my well-being.
Okay, but since you mentioned the problem of, let's say, obesity, hypertension, and I'm, please correct me if you think I'm talking stupidity. Don't you think these are, let's say, not the most lethal diseases as opposed to, let's say, pulmonary problems or renal problems, which are much more expensive to get treated? And let's say offering very proactive healthcare for even the most basic kind of diseases, for instance, hypertension, is just wearing off time of the healthcare providers.
Well, I wouldn't say that there is a choice here. Why is renal failure taking place? Because hypertension was not managed well. If you simply waited, for example, diabetes, Thiruvananthapuram and Pathanamthitta, 2 districts in Kerala, have the highest diabetes burden in the country and amongst the highest in the world. Right? Now, if you said that's a minor disease, they can figure it out, even if it's not treated, doesn't matter. Well, this proportion is growing at a reasonably steady rate every year. It was 6-7% in 2015-16. It's 20% now. Right? Now, let's say by 2030, this becomes 50%. I don't know the number. I have not done the modeling. I'm just coming up with a number, 50%. What is the consequence of diabetes? Stroke, blindness, amputations, kidney failure. Right? So now you're looking at a population, half the population, at risk for all these diseases.
Right.
Now, at that point, when you get somebody with a foot with gangrene in it, or they have lost their eyesight, the most expensive treatment in the world can't do anything.
Right.
I have to take care of it today.
Right.
There
But
are multiple cancers,
Mhm.
cervical cancer, breast cancer, colon cancer, oral cancer, lung cancer, blood cancer. If I pick it up early, very high cure rates. Blood cancer cure rate is as high as 95%. I pick it up late, right? Cure rates have collapsed to 20%, 25%, 5%, 1%. So you have to do both. I'm not suggesting to you at all that we should do this and not do that.
Mhm.
I'm not saying that. I'm saying the resource envelope that we are currently have, right now we're talking about the rich,
Mhm.
is more than enough to do both.
Right.
We're just not doing it. We don't have that design, either for the rich or the poor. And the point I'm making is if we build a good health system, everybody benefits.
Okay. I was reading this book called Poor Economics by Abhijit Banerjee, the Nobel laureate, and just want to draw an analogy here, right? Do you think because, let's take the particular example of Kerala again, and maybe those two districts, Pathanamthitta and Trivandrum that you mentioned, do you think they are not, because they take things for granted, because they have access to better healthcare, or at least better financial support for healthcare, do you think they take it for granted and that's the reason they're not able to maintain a much better lifestyle, which is focused on preventive healthcare?
I mean, not necessarily. The reality is, as human beings, we have evolved to believe we are immortal. Because otherwise, if we became too risk averse, nobody would go out and hunt for the saber-toothed tiger, right? The species would have collapsed because life is risky. So I don't think that one can say it's your fault. You should have done better. Right? There are a number of systemic factors at work. Price of food has collapsed. Calories are much cheaper today than they ever were. Right? Lifestyles have become sedentary. Our cities are not being designed to naturally induce walking. Right? I don't know if you've been to Cochin recently. It's virtually impossible to walk there.
Yeah.
Right? So the reality is that there are a number of factors guiding us to where we are. And it's not just an Indian problem, it's happening worldwide. Why in that environment has a country like Iran, for example, been able to build very strong control of all these diseases? Not because they were waiting for people to have a sudden flash of realization, oh my God, I'm leading a bad life, I should now lead a better life. Because that most people would know that they're getting fat, that they're getting more tired, they should be doing more exercise. You ask anybody, nobody will say that I should not do more exercise.
Right.
The problem is somebody has to work with you. What has Iran done? Iran has identified one individual health worker, could be a doctor, could be a non-doctor, per 1,000 people. And I've told her or him that you are responsible for the health and well-being of these 1,000 people. You have to make sure they've got all their checkups done, whatever medicine they need, they have to take it, identify 5% who are at high risk, make sure that you're dealing with it. If you discover any social problems, that child is getting abused at home, there is not enough food, the house is not good, talk to them about what they can do, turn to the community to help with it. And if nobody can help, look at what government can do to help them out. What we call social determinants of health. If they have a bad lifestyle, they're not walking enough, they are eating, you go shopping with them and make sure that they find food that is good for them. Are they eating too much salt? And what I'm talking to you about, from sitting from India, it looks like a utopian idea. But the reality is that India, US, there are only a few countries that don't do this. Most other health systems have realized that this is the core of, with this logic, there should be no healthcare problems in Germany, France, UK. They're all much richer than even Kerala. The countries that have paid attention to these issues and have built a primary care system that is proactive, that is, risk-based, have addressed it.
Okay, how exactly does, let's go back to the example of Iran. How exactly does the economics of this work? You mentioned that there is one healthcare provider, could be a doctor or non-doctor for, 1,000 people, and they are responsible for the healthcare of these 1,000 people. And when you have, let's say, a national health subsidy or, something like financial support for healthcare, does it result in, let's say, this particular healthcare provider sort of exploiting the situation to maybe charge these patients a higher amount or having a high ticket gate pass for them to have better treatment?
In Iran, it's free healthcare. There is no charge for anything.
Right, but when we replicate the same model to a country like India, do you think such kind of
now again,
state
by state it varies.
Mm-hmm.
I have a new paper that just came out a few weeks ago,
mm-hmm.
in which me and my co-author, Dr. Shukla, we look at how much will it cost to deliver this kind of service. Right? We first of all find not much state by state variation. We come up with some range of estimates from 1,600 rupees per capita to 2,500 rupees per capita using 2018 prices.
Mm-hmm.
We say, let's work with 2,000 rupees as a point estimate
mm-hmm.
to do our discussions and do our subsequent calculations. There are 13 states in India that are currently government is spending more money than that. Kerala is at 2,500 rupees. Delhi is at 5,000 rupees. I think Goa is at 5,000 rupees. Arunachal is at 10,000 rupees. So they are all spending enough money to deliver the kind of healthcare that Iran is delivering. From government resources. I'm not talking about people paying and all that.
Right.
Now, of course, the next natural question is, well, if the money is there and the people are sick, so it's not even as if I'm saying, give me more money.
Right.
I'm saying I have already enough money. Why am I not converting this into good healthcare? And this comes back to our original discussion. We need local designers to sit down and say, what is it that I need as a state?
Okay. So at this point, the crunch is not with capital or resources. It's about having
in the north it is. In the north it is. There are many states in the north that are spending a fraction of this money.
Okay.
So Bihar needs to multiply its current health expenditure by 4 or even 5 times in order to get to the minimum. Particularly, I'm concerned about 4 states, Bihar, UP, Jharkhand, and MP.
MP, okay.
These are the 4 lowest spenders.
Okay.
But there are many states that are spending more than that, more than 1,000 rupees per capita. But, I would say they all need more money. But there are many states, 13, I think is the number that we come up with in our paper, that, are spending more than what is needed. So unfortunately, the divide, all of us are getting bad healthcare.
Right.
But half of us could have gotten world-class healthcare with the money we are spending, but we are not. The other half just don't have enough money
to
get it. But maybe if they design their systems better, when they do have the money, they will get better outcomes with it.
Very interesting.
Aggregate, there is still a shortage of money. I'm not going to tell you that we as a country are, as a government, spending enough money. But there are many states that are spending enough money. And the Iran-style system, Costa Rican-style system are within reach.
Right. But why do you think government support should always be, let's say, in terms of upfront spending or grants for these, healthcare support? And why not in the form of, let's say, credit, not necessarily insurance, but credit?
There are multiple kinds of expenditures. If I look at healthcare, right, and I break it up into primary, secondary, and tertiary care, each of them has a different logic as to why credit doesn't make sense.
Okay.
In primary care, if I told you, you have to pay, and you have to borrow and pay if necessary, you will not go and seek preventive treatments. You will say, tomorrow, day after, the day after, I'm not going to do it because I don't feel sick. Cervical cancer starts at the age of 18. I will see the cancer at the age of 45. I feel fine. Right? Why would I go out there and spend 200 rupees if I have to spend it? Right. So oftentimes in primary care, we use the word not insurance, but prepayment. So So it's better to have a subscription type model. And ideally, people don't buy subscriptions on their own. Government has to give the money for primary care. It may not provide it. In many countries, government doesn't provide primary care, but it pays for it.
Mm-hmm.
In secondary care, or let me start at the other end, tertiary care, right? Let's say I got, spleen cancer. That's 25 lakh rupees,
Mm-hmm.
right? There's no way my lifetime income is going to be able to pay that back.
Right.
Net of all the other obligations I have. Now, the beauty of spleen cancer or any other cancer, pancreatic cancer, is that not everybody is going to get it. These are very rare cancers, right? If we said, let 1 lakh of us come together and we agree that one person will get it, but we don't know who. Why don't we all contribute 10 rupees or 20 rupees each? So that anyone who gets it, the pot of 20 lakh rupees is available to that person.
Right.
Now, again, spontaneously 1 lakh people don't come together and sign.
But isn't that what insurance is all about?
The issue is insurance is all about that. If 1 lakh people came together and bought that insurance.
Right.
Right. But the evidence is most people don't buy it because it's a rare disease. If I told you tomorrow, are you protected against pancreatic cancer? You'll say, are you crazy? It's such a rare disease.
Yeah.
I'll get more likely to die crossing the road.
Yeah.
Right.
Yeah.
So again, government has to step in because they are the natural entity that pools people together.
Mm.
Now, with secondary care, the problem is that secondary care is very tightly linked to primary care. It's also linked to emergency care. If I have a road accident, I'm in trauma. Right? Whether or not I have insurance, whether or not I have money, I must be taken care of within 1 hour. Right? Now, it is possible to fund it through some form of credit because it's often enough you will get these instances that your lifetime income may be enough.
Right.
Right. But it's very tightly linked to primary care. If you didn't do good primary care, you're likely to have more secondary care.
Makes sense.
Generally, the view has been, therefore, for primary, secondary, and tertiary care, it's better that this decision-making of funding it is taken out of individual hands and government steps in to say, I will charge you taxes. If you are a blue-collar or white-collar worker in a formal company, blue-collar workers have to pay ESI. I will launch another scheme like ESI for white-collar workers. But one way or the other, either through taxes or some other form of compulsory payment, I'll make you pay. And whoever is eligible has to pay. Right? And the best source is taxation. In fact, I have another paper that came out several months ago in which I look at all countries in the world and ask the question, what are some of the important characteristics and preconditions for outstanding health systems? No country, not even a single exception, has been able to build a good health system with good protection, good outcomes, good responsiveness, without at least 75% of the money coming from the government.
But when you recommend taxation as a solution, I mean, let's consider income tax, for instance. Less than 5% of the country pays income tax.
And tax to GDP ratio in India is 16%. Thailand tax to GDP ratio is 16%. Iran tax to GDP is 7%. We have enough tax. Because much of our tax is not direct taxes, but indirect tax.
Right.
And we have enough taxation. We could always have more. Question is not that. Question is, we spend 5% of our budget on annual budget, state or center, on health.
Right. Okay.
Thailand spends 15%.
Okay.
Iran spends 21%. It's a decision those governments have taken of how they will prioritize the current budget expenditure.
Got it. And if you were to, let's say, make one change in the existing budget, what would you give lesser priority and promote healthcare up the ranks?
So first of all, in many states, as I said, 13 states, even at 5%, there is enough money. So I would say to them, don't worry about increasing your budget. First, use this money well and build a good health system. A Goa, a Delhi, a Kerala. Right? Now, to the northern states, I would say to them, what are you currently spending money on? Is it not possible? For example, let me give you an example. India has a road density that is second only to France.
Okay.
We are well ahead per square kilometer of China, well ahead of the US, well ahead of most of the developed. Why are we still building roads with government money? Not entirely clear to me. Second, if you say, no, we don't have enough highways, we don't have enough infrastructure, this, that, and the other. I was a banker for 25 years and I ran corporate finance, project finance. I have the belief that we can fund all of this through the private sector. I don't need the government to be spending this money. Right? If I look at the subsidy bill of the government on fertilizer, agriculture, and so many other components, my submission would be, why do you need to spend all this money on subsidy? Right? People overuse fertilizer that they don't need. Credit subsidy in a market where labor is surplus. Why are you subsidizing credit? Because that's a capital subsidy. Like, why are you encouraging automation through your subsidy regime? Naturally, if it happens, that's fine. But you're almost incentivizing farmers not to use labor. Why are you doing that? Why not withdraw from these markets? If you do have poor farmers, give them a direct cash transfer, which we now through UPI have the ability to do. I chaired a committee for Reserve Bank of India in 2013. This is exactly the recommendations of that committee.
So it's about
anything new.
Right. So it's about reprioritizing how subsidies work and giving a priority for healthcare.
I would say more broadly, we should prioritize growth and welfare. Okay. Current allocations are neither good for growth, which means they don't help the rich, nor do they help welfare. That means they don't help the poor.
Okay.
Now, I can understand in 1947, it made a lot of sense because industry was not there, capital was not there, markets were not there, bond markets were not there. Today,
it's not relevant anymore.
I mean, I would say one could make different choices. Now, I wouldn't, one would have to spend a lot more time in detail to figure out which specific subsidy do we get rid of today? What do we do 4 years from now, 5 years from now? That's more detailed work. But at a broad brush, there is a lot of expenditure that we are putting out that, in my view, doesn't help us on any dimension that we are committed to as a country, growth or welfare.
Got it. So maybe switching gears a bit, going back to your experience of 2.5 decades in the world of banking. I recently had the former chief economic advisor, Dr. KV Subramaniam, on the podcast. And one of the things he mentioned is, again, it adds up with the numbers that you mentioned. 6 out of 7 people in India do not have access to credit. Why do you think this is the case? And how exactly can this be improved? And why is, let's say, something like the microfinancing approach or the Grameen Bank approach that was practiced in Bangladesh not applicable to a country like India, despite we having surplus of labor?
Well, let me start backwards a little bit.
Okay.
We have actually a very vibrant microfinance industry, and we learned it from Dr. Yunus. The earliest pioneers in Indian microfinance were, at least some of them, many people like Dr. Vijay Mahajan came up with these ideas separately, starting with much more an Indian notion of self-help groups. We've always had a tradition of bhajan mandalis and, women getting together and helping each other. So the Bachat Gat, the savings group, was an idea that was there already. Converting that into lending was something that was already being explored by the Indian entrepreneurs like Dr. Vijay Mahajan. But a number of new innovators, particularly those that started the MFI NBFCs and the joint liability group, much smaller group and much more purposely built for credit alone, we learned from Bangladesh. And this movement has gone quite far in India. So I wouldn't say that we have not used those ideas. Sad reality is both Bangladesh and us are in the same boat as far as credit to GDP is concerned. Right? It's not as if microfinance is going to address all of these concerns. Right? There are many domains which are beyond microfinance. And even microfinance is focused on the top 5% of women in a particular village. If you go look deeper in the village, you will still find most women have not received credit, or they have not received adequate credit, or more importantly, they have not received credit that is good for growth. They have received credit that is a substitute for savings. But if you ask them the question that a big businessman can get a project finance loan, right, and the loan repayment will come from that business, are you able to access such loans for your businesses? The reality today is no. It's not possible to do that. So, I mean, clearly it's an important domain of, concern as to why are we not able to get credit access going fairly quickly in the system. As many people as you talk to will have their own sets of ideas as to why this is not working. I certainly have my own set of ideas, drawn a little bit from the committee's report that I chaired in 2013. I wrote an op-ed recently that asked me to look at 10 years on from that committee, because it's 2023 now, what has been unfinished. And I would say, while many more new ideas I'm sure will be there, there are many ideas from there that are not yet receiving all the attention that it should. Let me give you an example. Right. Today, there is a strong layering of capital on what we call the non-bank finance company. Right. There is no logic for why that should be the case. It's not a deposit-taking entity. It is a business entity like a steel company or a paper company or a cement company. It is being lent to by banks. It is not raising retail deposits. Why must there be capital leverage? It is not clear. Right? On the contrary, what is happening is that the sum total of our policy is making non-bank finance companies safer and pushing banks to become riskier by saying to them directly, you must do this, directly, you must do that. Right? My submission would be that the original idea that we had was a sound idea, which came, I think, out of the Narasimhan Committee report in 1991. Allow the non-bank finance company a lot more freedom, a lot more play, no need of capital regulation until they cross 50,000 crores or 100,000 crores. And allow them to go out into the market and experiment and fail and offer the products and services that are needed. Today, we have hamstrung that sector. We have said to that sector that unless you achieve a certain size and unless you put a certain amount of capital, etc., you are not going to be able to function. And even when you function, we will put you under a fairly straitjacket of what you can do and what you can't. Right? I don't think that's consistent with good access to credit taking place. If I look at, for example, the insurance industry, why is it that we have a minimum capital requirement of 100 crores to set up a new insurance company when France has 15 crores as a requirement in a far more complex, a far more developed market? Not entirely clear why. There seems to be no prudential reason for
it. Is it just an attempt to protect the capital of the NBFCs?
But for what reason? These are investors that are commercial investors. The lenders are commercial lenders, sensible, smart lenders who you think are smart enough to lend to paper, steel, cement. Right? Why would you protect the investor? Somebody will say, why don't you protect then startup investors in other industries? Why are you protecting them only in this industry?
Is it because, let's say, the VC or the startup investor industry is much smaller in scale?
Not necessarily. I mean, there is no such protection being offered to them in any other sector.
Okay.
Right. And you're preventing them from experimenting. Not only that, you're hurting them from growth, because what are you saying? Then now let's take the 10% margin that an MFI is allowed to charge. More than half of it is because of regulatory requirement.
Right.
Because you ask for all this capital, the capital has to have return. Why are you asking the poorest person to pay an extra 7%? Because the money is not coming out of anybody, rich person's hands. This money is translating into a higher interest rate for the poorest borrower in the country, supporting a rich investor in NBFC. Why?
If we were to consider this thesis and say there were a handful of NBFCs that came up that were solely dedicated to, let's say, give credit to the bottom 95% women that you were highlighting, the reason this does not exist, do you think, is because the risk involved is too high in terms of them not having enough repayment capacity, simply because...
No. And I'm not even saying that. Well, first of all, we know from the failures of NBFCs that NBFCs are quite prepared to take risks. Right? That's not their fundamental challenge. In fact, you want them to take risks. By layering capital, you are telling them, no, don't take risks. Because now you have capital, more and more capital to worry
about.
Right. But let's say for a moment, we allowed them to do this. Why only to women? Why not to the local grocery store? Why not to the local businessman? Many of the women don't want to do entrepreneurship. They want a job. But if you don't allow a credit ecosystem to emerge in a community, nobody gets access to credit. Why not the plantation agriculture, for example? Why not somebody who is setting up a garage? Why not somebody that wants to set up a local chain of tea shops? He's not a poor woman, but he will hire a lot of the poor.
Right.
Credit has to be made available to everybody. Credit is like a road. You can't say I'll build a road only for poor women.
Right.
It must be a broad, high-quality road that anybody that is not drunk should be allowed to travel on with no difficulties. And if there is a toll to be paid, they must all be charged a reasonable toll.
But do you think there is enough willingness amongst the TG that you mentioned, which includes, let's say, self-employed people to take credit to just expand their business?
There is.
Okay.
There is a natural growth. See, at the end of the day, again, it's one of those questions, how do we answer? And there's nothing prevents us from making credit available and then see.
Right.
At most, what will happen? Nobody will come to the shop. Fine. The issue is, it's one of those things you can't say, I don't know if people are thirsty. Until I realize they are thirsty, I will not supply water.
Right.
Credit is a universal requirement. I mentioned to you earlier, Thailand is 180% credit to GDP ratio.
Yeah.
Most of our districts don't cross 20%. We have a long journey to go before we say, oh, we have too much credit. And without credit, how will you expect growth? How will you expect national growth? How will you expect regional growth? Without insurance, how will you get protection?
Right.
Without the ability to invest in mutual funds for the poorest person with the 1 rupee, 10 rupee, 15 rupees, how will you get diversification? Then you will complain everybody's buying gold, everybody's buying land. Well, you didn't allow us to do anything else.
Okay, very interesting take. So you think much lower ticket size investments should be propagated as an idea?
I'm saying you need channels. It's not simply a ticket size issue, right? Where do I go to invest my money? I need a channel. Is there a channel available to me in my neighborhood village? No. And the broad point I'm making is that we have not, and there is no prudential reason.
Right.
This is some other logic that is preventing us from offering these services to these remote populations. It's a matter of profitability. Let the local guy figure it out. It's not our responsibility to protect investors.
Right.
They are freewheeling people. They are putting money into companies that have never made money for years, and they are pouring billions into it.
Right.
Nobody is saying, I'll protect you. They have a logic, and many of them made lots of money also. They are not fools.
But I mean, just to counter that, it's also true at the same time that it's less than 1% of the VCs that are able to really make a return on their investment.
That's their call, right? I'm saying, why must we as a regulator say, oh, we have to protect the VC's return, so we will not allow poor to get credit?
Makes sense. And hypothetically, if we were to, okay, let's grant this particular idea that don't protect NBFCs anymore. Parking that thought aside, what else do you think are ways to improve access to credit in the country?
No, so clearly you need a channel.
Mm-hmm.
You need to allow a lot more product innovation. Let's take an example. A farmer today is exposed to two big shocks. If there is rainfall failure, he goes under. If the rainfall is too good, the commodity price falls.
Right.
Again, he goes under.
Mm.
In that environment, what we have done is we have insisted on simplicity as the principle, not suitability. We have said transparent, high quality interest rates, visible, easily computable interest rates is what we will permit and what the farmer deserves. So we ask him to take a 10,000 rupee loan and he has to pay 1,000 rupees back. What if the rainfall failed? What if it was too good? What he's got actually is a short position on an option.
Right.
Right. Now, what he needs is a set of products that allows him to neutralize this. If I was an Australian farmer, wheat farmer, I could go to the Commonwealth Bank of Australia internet banking site and buy the put and call options that I need.
Right.
In India, it's banned by law.
Mm.
Why? Why can a bank not offer these OTC options? We are permitting them to offer currency options.
Mm.
We are permitting them to take open positions on the euro.
But you're not allowing to hedge it.
What do they know about the euro? They have 40% of their portfolio committed to farming or priority sector. You're not allowing them to access these markets. You're not allowing the banks to do it. You're not allowing their clients to do it. I'm not able to see a prudential reason.
But do you think access to these products is going to significantly help them hedge their risks?
I mean,
and is there
as a banker, I would go to the farmer and say, well, sir, here is a loan. If it doesn't rain, you don't have to repay.
Okay.
If it rains too much and the commodity price falls, you don't have to repay.
Okay.
Only if the commodity price and the rainfall in a corridor, what we call a strangle, that you have a repayment obligation to. So why not? This would allow the farmer to take on. Basically, what we are saying to the farmer is you're exposed to, using finance jargon, you're exposed to two kinds of risks. One is idiosyncratic, one is systemic.
Yeah.
I'm taking away systemic risk from you. Why? Because you have limited risk-bearing capacity. Now, if I took away systemic risk from you, you can take a lot more idiosyncratic risk.
Hmm.
So you can expand your business much more aggressively because you know that if rainfall fails, you don't have to pay. If the commodity price falls, you don't have to pay. Now what matters is, am I a good farmer or not? Am I a better farmer or not?
But what do you think are some traits of you, specifically the banker, that allows you to offload the risk of the farmers, offload the systemic risk of the farmers?
No, I didn't hear your question properly.
No, what do you think are the traits of you, the banker, who gives them access to these credits that allows you to offload the systemic risk from the farmers?
I mean, we already built the NCDEX. So I don't have to do much. I offer the product to the customer. I aggregate the risk at my end and I lay it off on NCDEX.
Hmm.
That's what I do in any other risk product that I've got.
And do you think, sorry to cut you there, but do you think NBFCs have the potential to do this and not just banks?
Of course. Of course.
Okay.
So I'm just giving you some examples of issues that are missing. I've written about them in the most recent op-ed that came in Business Standard.
Okay.
There are many such considerations. And in the report, we had outlined many such gaps. For example, we spoke about ticket size.
Yeah.
One of the ideas we had left in the report was that the clearing houses should be given a banking license, what we call a wholesale payment banking license. Euroclear has it. The British clearing houses have it. Why? Because now it allows them to bank directly with the Reserve Bank of India. It does 2-3 things. One, if there is a crisis in the market, the Reserve Bank can extend a lender of last resort support directly to these institutions. Two, it can get early warning. Because of unusual activity in a clearing house, it can get an early warning as to that, because these are systemically very important institutions. Three, which is where the inclusion point comes in, because now you have ensured that the security and the cash clear instantaneously. I don't need the credit guarantee fund anymore. I can drop the transaction size to 1 rupee. So the futures contract size can become very low, because there are no costs associated with transacting it, or very minimal costs. We have not gone ahead and done it, even though there are good global examples for us to follow. In fact, the whole idea of payment banking came from that, from Euroclear, from these entities. The retail idea was supposed to be considered for if the payment infrastructure is not moving forward.
Right.
We gave the retail licenses, but we didn't give the wholesale licenses.
The bottom line of this is basically allowing them to have more risk-bearing capacity.
No, in their case, in the clearing house's case, it was more that they don't need the layer of a bank, commercial bank in the middle. They can directly bank with Reserve Bank.
And as a consequence of that, they have access to lender of last resort support.
But that's a defensive play.
Okay.
But the more interesting reason, on a day-to-day basis, we hope they don't fail and they don't need lender of last resort. But day-to-day, they now can clear transactions instantaneously.
Okay. And this is one of the ways you think just settlements of investments can happen faster. Yeah.
Contract sizes can go down. Then I can go to a small farmer and say, why do you want to bother with intermediaries? Directly trade on NCX.
Very interesting.
Because now you can do a 5 rupee contract. You can do a 10 rupee contract. You don't need 5 lakh rupees.
Very interesting. Okay, but maybe switching gears to your personal motivation, Nachiket. What drives you at this point?
No, I mean, my motivation is not anything unusual. All of us are trying to do, you are trying to do what best you can with your skill sets and capabilities. That's what I'm trying to do. I'm working in healthcare now. I believe healthcare is a complex area. I mean, everything is complex. Healthcare is also complex. And I'm trying to build some capacity to understand some aspects of that complexity. Like primary care. Why does it work? Why does it not work? Insurance. Why does it work? Why does it not work? What can we learn from studying other countries? I'm like one of many researchers that are studying these issues. The hope is that over a 5-10 year period, we will all have some insights that will be of use to a policymaker, to a decision maker who says, okay, I'd like to reform my health system. What is the net advice you have for me?
Do startups have any role in this game when it comes to making healthcare more accessible and affordable?
Of course they do. Of course they do. I mean, there are, for example, let me take some specific problem areas in which startups are already working. Today, in a remote district hospital, I can get an MBBS, but I cannot get a specialist.
Right.
Today, with tele-ICU startups, I don't need to bring the specialist in there. In fact, I don't even need the specialist to be locally in the neighborhood. So long as I have an MBBS doctor at the front end, the specialist can hold hands and do many, many things. And as optic fiber networks expand, what we can do remotely will go on getting better and better. Right? And there are many startups that are doing wonderful work in this area. Let's take another field, digital microscopy. One of the biggest challenges today in our country, anywhere, forget remote rural areas, even in urban areas. If I am a doctor and I told you, well, sir, I'm concerned about your health, why don't you go to the diagnostic lab and get a checkup? Get this test, that test now. Half the people will not go. Much better that when you came to me, whatever was needed to be done, I did it. Now, this problem becomes even more if you go to a remote area. Right? So now there are people that will allow you, because drawing blood is a skill people can be taught quickly. Right. A local nurse can do it, a local doctor can do it. Preparing a slide is even easier.
Right.
Now with a digital microscope, I can take high definition shots of it. Not just that, if I have good optic fiber connectivity, I can give a joystick to the back-end pathologist that he can look at my slide as if he was sitting with me. That changes completely what I can do with diagnostics.
And who are the biggest winners because of this? Is it rural population?
Everybody, I would argue. Yes, rural for sure. Anybody in a remote area for sure. But all of us have drop-offs. If I could look at you and the one meeting, I don't need you to come back. I can figure it out. And there are many, products, many secretions we have, spit, urine, that I don't even need to go anywhere. Right? So clearly there are startups in this space that are doing just marvelous work in this area. If I look at cancer, right, there are a number of new technologies that have emerged. One of them, for example, is thermal imaging. Right. We know that cancers have high metabolic rate.
Yeah.
And unlike our other body parts, a cancerous tissue is irregularly shaped.
Yeah.
So now a thermal scan looks for irregularly shaped hot areas in the body and suggests that they may be cancer.
Yeah.
Then you combine that with another terrific innovation, which is tele-ultrasonography, in which all I have at the front end is the ultrasound transducer. I don't have the machine, I don't have the screen. Now I'm being guided which part of the body to scan my transducer in. It needs some training. It can't be done without training. But with that training, I can now tell, does this cancerous tissue have blood flow in it or not? Does my heart have a blockage or not? Is my kidney the right size or not? Is my prostate the right size or not? Do I have a tumor growing somewhere? So, I can give you a million examples. Startups clearly have a lovely role to play, and they are taking risks. That's the point we were discussing earlier. Nobody's out there saying we'll protect you.
Right.
And because if somebody protected them, they would not be able to take the risks they are taking. Many will fail. Many will find that the business model is not working, or the product that they've invented is not what was needed. But the beauty of that is, in that, there will be every 1 in 10, 1 in 5, a product that just change. People like me that engage with primary care, we are literally salivating at the thought of introducing these technologies to our primary care. We have millions of primary care providers in the country. What if we could give them all access to these beautiful technologies? We're not quite there yet, but it's on its way.
Very interesting. So you basically mentioned how startups are already playing a role, but do you think there are, or can you think of any open problem statements out there that you think startups could potentially solve?
Currently, I think we need more work on the financial insurance, those kind of areas. Right? Okay. If I look at today, the insurance industry in the health insurance space is very focused on trying to work with low risk young populations. We don't yet have enough players that are saying, I will work with high risk old populations. Everybody's going after this narrow pie. Unfortunately, the narrow pie is shrinking, and it's not a market that has enough. So there will need to be newer innovations in that space for sure. Right? And not yet there, but hopefully some will come along. Unfortunately, a lot of startups that have engaged in these spaces, they haven't innovated fundamentally. What they have done is they've taken offline processes, made them online. But the underlying problem, they have not solved. In fact, in some cases, they made it worse. right? Because, at least earlier, you were stuck to doing it in a particular way. Now with electronics, you can hurt yourself in many different ways.
Right.
So, but I would say that's a journey. Once people explore the obvious, then that is exhausted, then somebody will come up with newer and newer ways of doing things. So clearly, these are areas in which, in the financial protection sense, some work will have to be done. As yet, we don't also have, worldwide, there are products out there, but in India, we don't have. Today, a lot of primary care has become protocol driven. It's no longer about the black box AI that we were calling a physician. It's not good enough. There's too much error he's making. Knowledge is changing too quickly. There is a lot more need for protocolized guidance. And there are protocols that are emerging in cancer treatment, in osteoporosis, in this, that, and the other. But now you have to get tools that allow you to use the protocol very smoothly. If I look at, for example, global companies like Babylon and IDA, right? They have these tools. These tools have not yet come to India.
Do you think they have not come solely to primary care? Do you think it exists with secondary and tertiary care?
I would say in secondary, tertiary care, the protocols are less clear.
Okay.
You now need judgment. You now need training. You can't quite tell a cardiac surgeon that follow exactly this process. His or her training and years of specialization matters a great deal. Right? In primary care, because you're dealing with the first level condition, you're dealing with a range of issues, you can go about doing this in a protocolized manner, because you know that the protocol, ideally you want more false positives. You don't want false negatives. And if you send somebody up and say, well, madam, I think this person may have a cardiac disease, the referral doctor can say, okay, no, yes, whatever. Right? And there are many diseases like hypertension, diabetes, etc., that at least you can begin the treatment based on protocol alone. You don't need necessarily a referral treatment. But I wouldn't say that about a cardiac surgery, or I wouldn't say that about somebody who's got comorbidity, 6 diseases going on at the same time. I think the protocols are less clear there. So, many areas in which I think there could be more work, there could be, more guidance. But I'm enthusiastic about what the startup industry is broadly doing in this space. I'm less enthusiastic about what we discussed earlier. They need a space within which their solutions can be mainstream. They need feedback to say, this is what we need, this is what we don't need. And that's really where the absence of universal healthcare, the absence of focus on outcome-based healthcare is hurting us. Because then somebody could come back to them and say, we really need you to help us with this. If you can fix this, I'll give you an order for 3 lakh units tomorrow. Right? We don't have that.
So there's lack of interaction between healthcare providers and people who could solve for it with tech, basically startups.
Partly that, partly I would say there isn't enough of a focus on universality. There isn't enough focus. So there aren't even that kind of providers. Individuals are there who are sitting in their offices and doing transactional treatment. They may say, I don't care. I'm making enough money right away like this only. I don't need you to give me some new tech and this, that, and the other.
Right.
But if we were to build the universal healthcare system that we spoke about, this demand would become very urgent, because now I'm suddenly got to make sure people stay well, that I detect the cancer early, that I detect the disease early.
But at the end, sorry, you were saying.
No, I'm saying that's the point at which the demand will reach. That's the point at which those conversations at the scale needed. One odd provider talking to a startup is not enough. For a startup to make sense, I must give him orders of 5, 10, 20 lakh units.
Right.
Then, what happened in vaccines? Right? In vaccines, we were able to give orders of 500 million units, 800 million units. Then, one can start to say, okay, please put serious money behind innovating. Because if you give me the right product, I really can change both lives of the people I serve, but also your life. Because I'll give you business volume that you cannot imagine.
And who do you think should bear the cost of these, let's say, new tech? Should it be governments or healthcare providers or patients?
I mean, at some level, one would have to think of universal healthcare as being anchored somewhere in the government. Now, whether it is anchored by government paying for it directly, or whether they work with the ecosystem to do something, do they bring outsiders in? For example, the vaccine industry. The government did not give advance purchase guarantees.
Right.
Some independent foundations did. But that had a big impact because the foundations knew that if the vaccine got developed, the governments would buy it.
Right.
So somewhere government was there, but it wasn't doing the actual investing. But if somebody knew that all I need to do is to develop a great innovation, if the innovation meets these specs, then I have massive demand. Then I don't need the government to invest. Many private players will invest.
So the role of government boils down to taking the tech and innovations and transferring it to the market at scale.
Taking responsibility for the well-being of the people they serve.
Sure.
Once that happens, once that responsibility is taken, everything else follows from it.
Very interesting. One concluding question, Nachiket. If you were a fresh grad out of college, 23, 24 years old, what would you be doing today?
I mean, what I would be doing, I don't know, but my general advice to people, when they ask me this question, what should they do? My request to them is acquire some skills, become good at something, because the country has no shortage of passionate people. What we lack are passionate people with deep skills, and the problems in the world are complex. Find the problem that interests you. And I'm not, if you rule out one or two industries that I think are harmful industries, you become a hedge fund trader, you become whatever you become, because you all add value. There isn't a sense that, just because you're doing rural work, that you are adding value. If you're running a podcast, you're not adding value. Or if you are, trading equities, you're not adding value. I disagree with that. I think we need a vibrant, diverse economy, and that benefits everybody. Right?
Makes sense.
But you need to be good at this. You need to get into it and really deliver capability. Train yourself. Become a fine instrument that can really break through the complex issues. And when you're young, you have the mind to do that. When you get as old as me, everything is a struggle.
Got it. Thanks for the advice, Nachiket, and thanks a lot for being on my podcast.